Good afternoon. Let's do it again. Good afternoon. All right, thank you. We want to, with great enthusiasm, welcome everyone to United Health Foundation's 25th Annual America's Health Rankings. Thank all of you for taking the time out of your schedules to join us here at the night studio in the Newseum. And we know that we are grateful for the audience that's here, but also all of those who are watching this online. We appreciate your being with us. We are in this audience joined by lots of people that we really love, people from organizations like the AARP, from Academy Health, the American Medical Group Management Association, APHA, ASTO is here with us, Community Anti-Drug Coalition, the Congressional Hispanic Caucus, Delmarva Foundation, the Jen Corelli Group, National Association of State Alcohol Association. I will get in trouble by not mentioning everybody and say that Project Hope is in the house, Maya Tech Corporation's in the house, National Association of County and Health Officers is in the house, Unity Health, always in the house every year. And whoever I forgot, we really think that it's terrific that you're here. Before we go into our discussion with our panel today, we do want to give you a snapshot on this 25th anniversary report. It's an important story that's being told, and having the opportunity for a 25-year view longitudinally is a real gift. We have, through the years, been very careful to modernize the report with new measures and taking advantage of new data sources. But we've done so under the leadership of our independent editorial body under the chairmanship of the University of North Carolina School of Public Health at Chapel Hill. You'll be hearing about that. We've been very careful through our editorial body leadership to only make very small changes year over year so that we could have that longitudinal picture. And the story is one of good news and bad news. And all of you are sophisticated, so I'll just truncate it by saying the good news is that we're living longer. The bad news is that we're living longer sicker. That our life expectancy is now up to 78.7 years, which is exciting. We are glad to see the infant mortality rate decrease by 41%, our cardiovascular death rate by 38%, our cancer death rate is decreasing, and premature death is down by 20%. It is telling us that our medical care system is extremely effective at prolonging life and treating illness. We also know that these statistics are in part because of phenomenal improvement in tobacco usage. And now over this 35 years, a 36% decrease in tobacco consumption in our country, which certainly is reflected also in these statistics. The bad news is that preventable risk factors other than tobacco are worsening. And by the way, tobacco continues to claim more than 400,000 lives every year, as about 19% of our population still smokes tobacco, and it's still the #1 risk factor for preventable death and disease. But we look at obesity as a fundamental risk factor, and we now start to see 153% increase in obesity since we've been doing this report. We also see the prevalence of physical inactivity remaining at horrendous levels, and 23.5% of our population getting no physical activity other than getting up and going to work. As such, it's not surprising that the diabetes rate over the last 20 years has doubled, and that we now have 9.6% of the population suffering from diabetes. You put all this story together, there are an awful lot of people in America who are unnecessarily sick, who will need the services of a medical care system that we already cannot afford. We have got to change the conversation in American life from a medical care conversation to a prevention and healthy living conversation, and we have a long way to go if we're going to get there. Next slide. We do always tell the story of how our states are doing. We try hard not to have people focus too much on where do you fit in the rankings. We try to help people to understand that every state, no matter where it is in the ranking, has its lessons to share and its lessons to learn. Everybody has its challenges. I remember the first time, I've been doing this now, I think, almost 15 years. I remember the first time we really sort of ramped this thing up, and we were so excited. New Hampshire was #1, and we were putting it all over our press releases, and I got this urgent call from the health commissioner of the great state of New Hampshire saying, please, God, don't put that out. I'm in the middle of budget discussions, and you're going to kill me here. So we had to hurry up and say all the bad things about New Hampshire, even as we were saying how good they were doing. So every state has its shares of challenges and its share of successes. But Hawaii, once again, is the healthiest state, followed, as you see, by Vermont, Massachusetts, Connecticut, and Utah. And on the bottom, we see the continuing challenges faced by Mississippi, then Arkansas, Louisiana, Kentucky, and Oklahoma. You will note that Alabama is not in the bottom 5 anymore. And that's very interesting that they've started to move out of the bottom because they've done a better job at smoking prevalence reduction, reducing drug deaths, and improved childhood immunizations. And so that's actually pretty good. New York is a good state for those of you who want to follow an interesting state. Look at the reports. We won't have time in this brief introduction today, but New York is very interesting to us because they have moved significantly over the years. They're doing a lot of things well and a lot of things correctly. One of the most exciting things that we have initiated with this year's report actually came from lessons we learned from Louisiana, and that is something that we call Change My Rank on our website. If a state wants to know how can it in fact move up, we provide the flexible modeling where you can put in changed variables and see where you would have been if you can get certain parameters that are under your control within the state. If you can modify those, you can see where they were. Louisiana had a very, very progressive head of their health services committee who basically asked us that question 2 years ago and basically created a bill for the great state of Louisiana that focused on hitting all those things that they could change and made that a priority for the legislature in the state of Louisiana. That's leadership, and that's the kind of thing that we find to be exciting. The other thing we're very excited about is that we've joined partnership with ASTO in creating a learning laboratory where states now are looking at who's making the most progress in key areas and then using the lessons learned from those states and feeding it back to other health departments in a learning laboratory environment. So we are very excited by that. Finally, we have a new thought leader series that is a part of America's Health Rankings this year. These are thought leader perspectives. And so we urge you to go to our portal and see the thoughts of real luminaries. Now, again, you always get in trouble when you name a few and you don't name everybody, but I'm really excited that Francis Collins, the head of NIH, saw that his public leadership responsibility was such that he should lend his voice as the head of NIH to the healthy prevention fight. We were very happy that that Georges Benjamin is in there, and Jonathan Fielding, and Carolyn Clancy, and Donna Shalala, and Howard Wimmer, and John Sefrin, and Jennifer House, and it goes on in terms of the family that is now a part of what America's Health Rankings is all about. So, we have a lot of work ahead as a nation to create this climate of healthiness, and it requires people being vigilant and diligent over a long period of time. To start us out on our conversation today is my good friend, Dr. Georges Benjamin, the Executive Director of the American Public Health Association, one of America's most influential physician leaders. And we're asking George to give us his thought on this reflection of 25 years in this movement of health of the public. And George, we appreciate your thoughts.
Thank you. Well, thank you, Reed. So it's been a quarter of a century of actually measuring how we improve our health. And, I often get asked what we mean by health. Obviously, we have an amazing sick care system, but our goal, of course, is to have a health system So I like to use the World Health Organization's definition of health, which is a state of complete physical, mental, and social well-being, and not merely the absence of disease or illness. As a core definition, you notice that that's a holistic definition of health. And as you actually look at what America's Health Rankings has tried to measure over the years, is a holistic series of measures to see how we're doing. Now, we certainly think about this emphasis on not just individual health, but also more and more on population health or the health of a community. And we know that it's very important to measure what we do. We have lots of programs, but if you don't measure them what they do, it doesn't do you a lot of good. And what America's Health Rankings has done is, of course, measure the progress of the sum total of those programs. And, you know, we're a very competitive nation, and we know that as a nation, while again we provide amazing health care, if you get sick, this is where you want to be. But we're not as competitive in terms of being the healthiest nation, no matter how you measure it. We're not the healthiest nation. And so, as a competitive nation, I know the American Public Health Association believes that we should be, and that we should set as a national goal that we should certainly be the healthiest nation, not to take away from our colleagues in Britain and France and other places that are higher on our ranking of industrialized nations, but we should be able to compete effectively with them, particularly since we spend twice as much money in health as they do. So how do we get there? You know, number one, I think by doing evidence-based interventions, you know, looking at what we know. And if you look in the America's Health Rankings book, there is a list of things that people can do that that can help move them along in terms of us being not just an individually healthy state, but also for us being the healthy nation. And they include both clinical interventions as well as community-based interventions. The second thing, of course, is to measure our progress, and we should do that in a variety of settings, and of course the health rankings helps us to do that. And then look at where we are. Look at the things we've done well and do them better, and do the things that we've not done so well, and find ways to improve it. And Dr. Tuckson talked a great deal about the Louisiana experience in doing that. And you now see a tool in America's Health Rankings to help states to ask that fundamental question: how did you do it, and how can we do it, and how can we get better? So I just want to leave you with the fact that we're not just presenting a quarter of a century of progress, because we're glad to see that longevity has improved. But I think our next big quest is improving both quality of life and our community health. And so I'm hoping as we go forward that in the next 25 years, we will again continue to make progress. And of course, I'm hoping that in the generation of my children, we will indeed be the healthiest nation. So Reed, I'll turn it back over to you.
Thank you so much. One of the things that George mentions, and I want to emphasize, is this sense of this call to action, is the subtitle of the report. We don't want that subtitle of the report to get lost. We call this America's Health Rankings, but right below the heading is a call to action for people and their communities. And I think that's very important. We are also very pleased in terms of the guts of this report. This is a joint effort between United Health Foundation, the American Public Health Association, and the Partnership for Prevention. Each of us had an opportunity to recommend years ago a set of the most thoughtful, bright, and smartest people who think about the epidemiology of and the methodology for how you might construct such a report. And each of us got a chance to create or to suggest people that were smart and would be thoughtful. We couldn't think of a better place to go to have an independent, unassailably group of editors and leaders of this effort than the UNC Gillings School of Global Public Health. And over the years, we have been greatly benefited from Anna Shank, who has taken on the leadership role of this incredible panel of very, very smart public health intellectuals, methodologists, and statisticians who have shaped the body of this report, who shaped the measures. There is no influence that United Health Foundation, APHA, or Partnership Prevention has over the measures that are done. This is all done in a completely transparent and unassailable way, and we are very glad, Anna, that you are with us, and please give us your comments as well.
Thank you. So we heard Dr. Benjamin talk about the World Health Organization's definition of health, a complete state of physical, mental, and social well-being. But what does that mean for a state? So does it mean that it has low rates of disease? Does it mean that its residents have longer life expectancy? Or that the air and the water are cleaner there? Well, it's certainly all of those things. But public health is what we as a society do to promote that state of well-being. And this includes measuring and monitoring the health of communities, putting policies in place to support health, and assuring that populations have access to programs and services. And for the past 25 years, America's Health Rankings has provided a snapshot every year for states to assess how well they are doing in promoting health. And for the past 5 years, I've had the opportunity to serve as the chair of the Scientific Advisory Committee for America's Health Rankings. This committee provides consultation on the selection of the measures, and we also spend time looking at how the rankings are used. The state's overall rankings, as well as the individual measures included in the rankings, which include things like behaviors, measures for community and environment, policies, healthcare, and outcome, all can be used to identify areas that need improvement and to gain support for health policies, programs, and services. In the 25 years of the America's Health Rankings, we've seen dramatic improvements in a number of health areas, and you're going to hear about some of those from some of the other panelists. But it's important to know that while gains have been made, as a nation, we have a long way to go. You've heard that our outcomes are much worse than in other developed countries, despite spending a greater amount of money, a greater percentage of our resources on health care. Our health spending accounts for nearly 18% of our GDP, and our per-person spending is 2.5 times that of the average of other high-wealth countries. But we're not spending our healthcare dollars in the right places. We need programs, policies, and services that work to improve health. And we're not spending our healthcare dollars at the right time. We need to put our healthcare dollars to work preventing the leading causes of disability and death. And measurement is a key to helping us spend better. We can measure the impact of policies, services, and our progress in moving towards health goals. Now, I have spent most of my career measuring health, and I do believe in numbers. However, when you look at a state measure, we're looking at an average, and even I have to admit that numbers don't tell the whole story. We have tremendous variation in the health in our U.S., and that depends on where someone lives, whether they're male or female, their race or ethnicity, their income, or their education level. Earlier this year, I completed a study looking at a few of the individual measures that are included in the America's Health Rankings. The diabetes rate for Americans who did not graduate from high school is twice that of those who graduated from college. The percentage of people who smoke tobacco is nearly 3 times that for those without a high school education compared to those who went to college. Gaps like these will keep us from achieving our health goals. So we will continue to spend too much, too late, unless we start looking behind the numbers and identify and fix the causes of poor health and address disparities in rates across different populations. Thank you.
Terrific. For those of you that are taking notes, I would urge you to recycle that last quote. Spend too much, too late. That's beautiful. Sad reality, but it's a beautiful way to capture that message, and I think we ought to add that to our lexicon. I'm also pleased, by the way, that that this editorial scientific advisory board that Anna chairs so ably gives me an opportunity to also let you know that with us today is Tom Eckstein and Sarah Milder, who are our two colleagues. Sarah and Tom, would you stand up, please? These are the people who actually do the report for us. They are our people, and they labor too often in anonymity, and I'm glad to bring them forward. I'm now happy that as we think about this sense, Anna, that you talk about this sense of needing to move to action at the state level and to be able to make real implementation across states. I can think of no organization that is any better at doing this than the March of Dimes. And Scott Burns, I actually graduated from the March of Dimes Academy of community organizing and community engagement. And Scott has taken on the stuff that I used to do and made it 30 times better than when I was there. Scott is the Senior Vice President and Deputy Medical Officer for the March of Dimes. And please, Scott. Great.
Thanks, Reed. That was a very gracious introduction. It's a big shoes there to fill, I would say. First of all, congratulations to United Health Foundation, 25 years of doing this report. Thank you for doing that, and thank you all for being here today, and for those tuning in, thanks for tuning in. So my job at the March of Dimes is I support our chapters in their efforts to implement our mission. Our chapters are basically state-based entities, and our mission is to improve the health of babies by preventing birth defects, premature birth, and infant mortality. We just celebrated our 75th year, Reed, in existence since 1938 when we first started, up to combat polio. FDR started the March of Dimes back then with his law partner, Basil O'Connor. So I wanted to talk about premature birth, preterm birth, and infant mortality in my remarks here. And I would like to submit that preterm birth is one of the most intractable health problems we have here in modern medicine and in public health. And just to put this in perspective, so globally, there are 15 million children born annually prematurely. 1 million of them die. Premature birth, preterm birth, is the leading cause of death in children under the age of 5 years globally. The March of Dimes launched a campaign here in the US in 2003 to raise awareness about this issue. And by the way, premature birth is when a baby's born before 37 weeks gestation. Those babies can go on to have lifelong health problems. Costs our nation $26 billion a year. We launched this campaign, and when I came to the March of Dimes, the preterm birth rates have been going up and up and up for 30 years. I've been at the March of Dimes now for 13 years. So late 70s right through not too long ago till a peak of 12.8% in 2006. Now it's interesting, if you look at that 30-year increase in preterm birth in our country, you're talking about 500,000 babies a year. That's a lot of babies in our country. And you look at infant mortality rates, we've made a lot of progress with infant mortality, but if you look around the year 2000, infant mortality rates, they were coming down, they sort of leveled off, right? And preterm birth was going up. And it kept going up, and then it peaked, and we'd started our campaign back in 2003, and through our efforts and through efforts of a lot of partners here, we actually saw that peak of 12.8% in 2006, and for the last 7 years, preterm birth in this country has been coming down. And then you saw the infant mortality rate in 2007 also start to come down again in the United States, directly related, I think. So we hit in 2013, actually the Healthy People 2020 goal of 11.4% in the US. Still too many babies born prematurely. But over those 7 years with preterm birth rates going down, that's 230,000 fewer babies born prematurely. A savings to the US healthcare system of close to $12 billion. Yes, that's billion with a B, billion. And, but you know what, 1 in 9 babies in the US is still too many. We rank poorly in preterm birth rates globally, as well as infant mortality. The report points out we're 42nd, I believe, which is bad, and we need to do better. And just briefly, what can we do? And I'm just going to mention one or two things. And what we started doing, we have a national premature birth report card that we've had for the last 7 years. And the first report card that came out in 2008, we actually started talking about the issue of, this is just one of many I could talk about, but of early elective deliveries. So these are inductions or C-sections that are done with no medical indication. And the estimates are around 10% of births in this country are early elective deliveries. So we raised the banner, which we, I think, do well at the March of Dimes with our partners, many of you here, provider organizations, public health organizations, nursing groups, and others. And so what we have done is we put messaging out around that women should not be asking for, families should not be asking for an induction or a C-section before full term if they're having a healthy pregnancy. And we're reaching out to providers as well, because we need to reach out to both. And there's a lot more work we're doing. There's issues, we're doing things around smoking cessation. You know, rates have come down, rates are still too high. 20% of women of childbearing age are still smoking. A lot of work we need to do there. There's progesterone treatment for women who've had a previous preterm birth can significantly decrease the risk of a subsequent preterm birth. And lots of public-private coalitions, which we could probably get into later as well. Now, these are evidence-based interventions, Georges, that we could be doing to help reduce preterm birth and infant mortality, but we're really not gonna get to, we just put out a number in the journal called Pediatrics. We wanna get to 5.5% by 2030 in this country. And you know what? Discovery is gonna be the key. We can implement all the evidence-based interventions we know, but we still need discovery. And at the March of Dimes in 2011, we launched our first transdisciplinary research center at Stanford University. We now have 4 around the country. We'll be announcing a 5th one coming up in 2015. So we're out there at Stanford, we're in Ohio, we announced one at UPenn and at WashU in St. Louis. And what we're doing is team science. This is really innovative because we have scientists coming around the table, so talking about biologists, physicians, we also have economists and anthropologists and physicists all coming around the table to talk about what can we be doing to reduce preterm birth. And I'm hoping we could talk more about that later, but I'm talking about themes like the microbiome and things like cervical photoacoustic endoscopy, that's physics stuff. I mean, there's all kinds of interesting research going on out there, and I want to thank the United Health Foundation for inviting the March of Dimes, for inviting me to be here today, and I'm looking forward to our discussion the rest of this afternoon. Thank you.
Terrific. Well done. Good job. Moving our conversation forward, we're very glad that Chris Hansen, president of the American Cancer Society's Cancer Action Network, is here. And I think what we obviously are looking for and listening is, it's in the very title, it's about action.
Thank you. Well, it's good to be here today, and I want to congratulate the United Health Foundation one more time for the great work that you do. What I'm going to say may sound a little bit like I may sound like a professor of the obvious based on some of the things that have already been said, but I'm going to focus on cancer specifically. Fact is that we have made enormous progress in the fight against cancer. It wasn't that long ago that a cancer diagnosis was a virtual death sentence, but today there are 15 million cancer survivors living in this country. With the decline of the death rate from cancer that began in the early 1970s, we are now averting 300 more deaths a day from the disease than we did back then. And since the 1990s, the early 1990s, there's been a 20% decline in the cancer mortality rate. So the American Cancer Society and the American Cancer Society Cancer Action Network actually believe that we can avert 1,000 more deaths per day with what we already know through prevention, through screenings, et cetera. We know that if you stop people from using tobacco products, which basically about 1/3 of all cancer deaths are directly relatable to the consumption of tobacco, if you can get people to maintain a healthy weight and have healthy nutrition and have some moderate exercise, that prevents about 30% of cancer deaths today. And unfortunately, that metric is going in the wrong direction right now. And if you can get people to get their screenings, we can basically prevent more than half of those deaths. The aging of America is a problem, so what I just talked about is the good news. The bad news is the aging of our population. 1.7 million people will receive a cancer diagnosis in this country this year. An estimated 580,000 of them will die from the disease this year. And if you think about the cancer threat globally, it has the potential to kill 1 billion people in this century, which is terrifying. But again, we know what to do. The scientific breakthroughs that advance our ability to prevent and detect and treat the disease are a huge plus, and we need to keep them coming. We need to support innovation whenever we can. But we also know that the breakthroughs can't help people with access. Public policies have to be crafted that ensure that people have the access to the care that they need. Lawmakers and policymakers have an increasingly important role to play, not only in improving access to health care, but also ensuring that the federal government invests appropriately in scientific research and protecting people from the health hazards, such as tobacco smoke. Private sector involvement is critically important in defeating cancer. Companies engaging in research and development are producing more innovative drugs and devices and therapies that can save lives, and we need them to continue doing that. We need to incent them to do that. And we also know that companies of all types and sizes can play a major role in helping their employees make choices that are good for their health. And so CEOs need to incentivize wellness in their workforces. The American Cancer Society has a program called CEOs Against Cancer, where we have chapters all around the country, and they're growing, and a big national organization which is growing. And we're getting CEOs to really come together around the whole issue of wellness and incenting their employees to stay healthy, and to also do things where they demonstrate their own commitment to being healthy and so that they can walk the talk. Unhealthy employees can result in lost work days, lower productivity, higher costs, less certain bottom line. According to a 2012 study by the Integrated Benefits Institute representing major U.S. employers and business coalitions, municipalities, unions, and universities, poor health costs the U.S. economy $576 billion per year. $576 billion per year. And of that amount, 39%, or $227 billion, is from lost productivity alone. So we need to work together, private sector, public sector, foundations like the United Health Foundation, to overcome this. And thank you for listening to me today.
Terrific. Thanks, Chris. We are very pleased that Janice Nolan, Assistant Vice President for National Policy for the American Lung Association, is here with us. And Janice, we are really interested in your perspective from the hat that you wear.
Thank you. Thanks so much for the invitation for the United Health Foundation. I appreciate the opportunity to talk about something that you probably don't pay attention to much anymore, and that's good news. And I think one of the things I want to share is we've got some really good news. And that is the air that we breathe is much cleaner than it was 25 years ago. And it's cleaner than it's been since the early 70s, thanks to the Clean Air Act, which is probably one of the least appreciated but most important public health laws ever developed and adopted by Congress. The year I graduated from high school, the Clean Air Act was in its infancy, and Birmingham, Alabama looked like Beijing today. We have photos of cities across the U.S. that show us literally how much cleaner the air is today than it was then. Can you even remember how old that air looked and how bad it looked? Fortunately, neither can I, but we do keep records on that. And since the reductions began, I'll just say since 1990, in the last 25 years that we've been looking, we've seen enormous reductions, including ozone that's 23% lower, coarse particle pollution, but 1/3 lower, carbon monoxide and sulfur dioxide emissions, 75% lower, airborne lead, remember lead in gasoline? 90% lower, and other toxic pollutants, 62%. Some of those cause cancer, so these are really important public health preventatives. We've also learned more about the harm that these pollutants can create. We learned, for example, how deadly ozone and particulate matter are. They shorten life by months to years. Particle pollution is now recognized as a carcinogen, something that we hadn't appreciated even just a few years ago. And we're learning, for example, that there are more harms than just in the lungs or in the cardiovascular system. It's looking at the impact on pregnancy. Some new studies are finding that some of these pollutants actually can increase the risk of low birth weight. And so we're trying to look beyond the places that we've been and learning why it's so important that we have this cleaner air. The Lung Association has fought for healthy air for about 50 years now. In 2000, we launched our report card called the State of the Air Report Card. Each April, we give a grade to every county in the country that has an ozone or particulate matter monitor. And you may be surprised that we have about 3,067 counties in the United States, and only about 800 or 900 have air pollution monitors. But we took that information and we try to translate it into something that's easy for people to understand. So we put it into a report card. And we do a ranking. And that's something else that gets people. Because mainly we wanted people to understand that it wasn't just Los Angeles that had problems with that. Take Knoxville, Tennessee, for example. The first year we published the State of the Air report, Knoxvillians were stunned to find out that their city ranked 12th most polluted in the nation for ozone. Thank you, TVA coal-fired power plants. Using today's assessment of what unhealthy levels of ozone were, they had on average 60 days a year with unhealthy levels of pollution. In our most recent report, using that same measure, they're down to 8 days a year. That's still an F, but it's so much cleaner. The steps that got Knoxville cleaner have helped all of us to breathe easier. As a nation, we've been having reductions in emissions from things like cars and trains and locomotives, from barges and ships, and now from coal-fired power plant. We still have a lot more to do. On indoor air, though, the biggest change has been the growth of smoke-free air. Now, how many of you remember before we had smoke-free airplanes and we had smoking sections and non-smoking sections? That passed in 1990. Since then, more and more places have gone smoke-free, but not as many as you might think. For example, how many states do you think have comprehensive smoke-free air laws? 28, plus the District of Columbia. That means that people, especially workers, in 22 states remain exposed to toxic tobacco smoke on the job. Now, fortunately, hundreds of cities and counties have also passed laws like that. Smoking rates are down, excuse me, thanks in part to these smoke-free spaces. As was mentioned earlier, in 1990, 1/4 of the population smoked. And our most recent information that came out just a couple weeks ago say that that's down to 17.8%, so that's terrific. But we're concerned about new trends in products that have unknown health consequences, things that have grown at rates we could not imagine. For example, between 2012 and 2013, the use of e-cigarettes by teens increased by 61%. I'll be happy to talk as we get into it about things that we see coming in the future, but we're looking at concerns about climate change, about some possibilities of the impact on FDA regulation of tobacco products, and on lung cancer as we go forward. Thank you.
Thank you. So, by the way, on that smoking thing, one of the things that we do every year with the United Health Foundation is to partner with the Center for Tobacco-Free Kids. And they've got this terrific program called Kick Butts Day. And what that is you get the young people who go out and preach about how they're being marketed to for tobacco. So those e-cigarettes, the cigarellos, the wafers under your tongue. They even got stuff to put between your toes to put nicotine into your system while you're in class and nobody knows you're doing it. So those are really tough issues. Let me start this conversation, and I'm out here because I want to make sure that we get to you all as well on your questions. But this last point that you get to, Janice, around some of the laws and regulations that have done so well. So one of the biggest controversies in our space was sort of brought up this year and last year in New York City, with Mayor Bloomberg being very aggressive about using the power of the political establishment and the regulatory power. And you hear these disparaging comments about the nanny state and those kinds of things. How do you all sort of view, and let me get some quick thoughts from you all on, how do you view this role of regulation, the role of political and elected official leadership in being a part of this conversation? Anybody wants to take that?
Go ahead.
I'll say the Clean Air Act shows how effective that can be. I mean, we've had that law for 40 years now, And as a result, we've seen enormous cleanup. The same measures were available in many cases to the states to do before, and only one, California, stepped up to it. The Clean Air Act also made an aggressive approach toward making health as the basis for the changes, so that we had to review the science every 5 years and determine whether we were providing the protection that was needed. It also helped drive innovation. It helped require that people learn new technologies that would actually, we didn't have, for example, catalytic converters when we created the Clean Air Act. So it's been a very effective tool. Policy change can make a huge difference in ways that people aren't even aware that's happening.
Great. Chris?
Yeah, I was just going to say, I think if you think about it, we spend a lot of money as a nation on national defense, and I think that we should. But the whole idea is that we're trying to protect people from something that could kill them, something that could really harm our society. I think we're dealing with exactly the same thing. I don't think it's a nanny state. I think it is actually trying to help protect people from things that we know will hurt them. You know, I think on tobacco, for instance, you know, people get hooked on tobacco when they're young. When you go through and you interview smokers, and over 70% of current smokers are trying desperately to quit, and they can't because they're addicted to nicotine. They get addicted before they know anything, frankly, and there's just peer pressure, and the advertising that's focused on children is very effective, and we've got to find ways to protect them from that.
Terrific.
Yeah, I mean, I agree with what Janice and Chris has said. You know, first of all, the March of Dimes, as I think we all are, we're a bipartisan organization, right? We work on both sides of the aisle. I think when it comes to regulations and laws, the most important thing from our perspective is that there's some evidence behind, you know, what you're going to be putting in place. And we have some great examples here. And one thing that popped into my mind, I mentioned these early elected deliveries, these non-medically indicated deliveries. So we'll have like a state legislature or someone, you know, from one of our chapters call us and say, should we be supporting a bill where Medicaid does not pay for non-medically indicated deliveries? Or should we do an incentive program or we level out the payment for cesarean deliveries and vaginal deliveries? And the answer is whatever works in your state for now, and then let's build the evidence to see what works best. So if legislation around not paying for these non-medically indicated deliveries is working, then that's something the March of Dimes would be more of a position to advocate for. Terrific. But we're all ears on this area.
So I agree that laws can be very effective, and the government definitely has a role. But one thing that we teach in introductory public health, for our new students, is that public health is a team sport. So there is absolutely no way you can go out and do public health. You've got to have the people behind you. And so there's a lot of work that needs to be done in terms of changing social norms and in the public-private partnerships.
Terrific. George, did you?
Yeah, policy change is probably the most important tool in our toolkit. It does have to be partnered, however, with a whole range of education. You have to build a knowledge base in the community and a demand for policy, and make your case. Because if it hurts people or kills people, it's ours. And if we did nothing about it, people would be dismayed. And the best way to do that is through broad policy change and community action.
I have to say that I wasn't planning on asking that question per se, but I, for one, found the comment about air pollution to be so compelling. I mean, it is kind of like weird. If anybody has been in, if you're lucky enough to live in one of those states with very strict sort of laws about that, you know, the idea that somebody would be allowed to imperil my health and screw up my air that I breathe, that somehow or another that would be somebody acting in a nanny way. It's kind of absurd in a way. And I think you sort of take it out of this false dichotomy between this debate that we sometimes get into around individual responsibility versus government. But on the other hand, we are not going to allow people to, you still have traffic lights, and nobody seems to be upset about that. So I guess that kind of makes sense. This idea, and by the way, I'm going to look for you to sort of signal that you want in on this conversation. And if you do not do that, then I'm going to call upon you like when you were in high school. But you're here because you're part of the family. This idea of public-private partnerships and collaborations has come up by several of you have sort of commented on it. And I actually guess, Chris, let me start with you in the sense that one of the things that we have had a tough time doing at United Health Foundation is to create a sustainable conversation with multiple partners. How do you get the business community to see that it needs to be involved in this drama? How do you get churches and civic associations and fraternities and sororities to marry with public health? How do we get our community organizations who are walking for healthy pregnancies, how do we get them to be a part of the process of changing what you call this cultural dynamic, this sense of culture? And more than that, how do you sustain it after the march is over? What are your thoughts? And again, any particular order you want, but how do we actually build this sustainable, multidisciplinary movement for health?
Well, I'm hoping that with the CEOs, the way to do it is to get them talking to each other about it. And that's what we're trying to do in this program, our CEOs Against Cancer program. And I find that when you put a group of CEOs into a room and you start talking about healthcare, you start talking about productivity, and you talk about the cost of healthcare, they all come online fast, and they talk to each other about ways to be successful in this. And I think that they're very interested in this. I think a lot of times people don't really approach them in a way that basically says, here's why you should be interested in this. And fortunately, people that are CEOs tend to be highly intelligent people, and I think a lot of times they listen to some of these lessons and they think, I really didn't know that. For instance, I know I was speaking not all that long ago to a group of CEOs in Denver, and mentioned to them the fact that about 30% of all cancer deaths are a result of people being obese, poor nutrition, lack of exercise. They were shocked by that. And when they have that knowledge, they tend to do something about it.
Yeah, I'll just follow up on that. It's exactly what we're finding. At the March of Dimes, it comes down to the bottom line for CEOs, really. I mean, they look at their costs. So we have actually an intranet. It's free, no cost for businesses called Healthy Babies, Healthy Business. And when they hear that the cost of a premature birth for their business is around $50,000 per birth, and when an uncomplicated delivery is around $4,000, I mentioned the 1 in 9 babies, right? If you take all the healthy babies and the total cost of all 8 of those babies, that one baby born prematurely costs more than those 8 other healthy babies combined. That resonates for employers.
We've had a similar benefit this year, especially working with the CVS, as they have decided to take tobacco products out of their pharmacies. And it was an evolutionary process for them to go through the corporate decision that this was something they needed to position themselves differently from the way that they had traditionally been, where you were selling products that would help people prevent the harm associated with tobacco, but you're selling the tobacco in the same building. And they've come to appreciate that and made that conscious decision. And I think it blended well with them understanding and appreciating the place they needed to be going, worked well with where we wanted them to be. And so we had a good partnership in the last year with them.
Terrific.
And there's an opportunity for other pharmacies to do the same thing.
Right.
Because if you're in the health business, you ought not be in the tobacco business.
Yep.
And we've got to learn to, I think, communicate more effectively to businesses. Talking about, do you really want to live and put your business in a community that's not a healthy community? What's the economic return on investment if you actually take your business where it is now in an unhealthy community and move it to a healthy community?
That's good. Let me give you a criticism of our community. Maybe we don't leverage well enough. Maybe we don't connect the pieces of the puzzle together. Maybe, I'm provoking you so I'm coming out here so the audience can protect me from you. Maybe we don't. Let me tell you what we did. At United Health Foundation, one of the smart things that Kate Rubin and Shelley Espinosa, who run the foundation, did was to give a grant to the National Business Coalition on Health to try to see if we couldn't get them to be more involved in the process of sustaining community planning and partnering with public health. And now I'm thinking and listening that you've got your CEOs against that. You've got your CEOs against. We've got your good. Maybe we don't come together. It doesn't matter at the end of the day whether or not we get the community to be involved in the tobacco fight, the AIDS fight, the cardiovascular fight, what if we just could get everybody together and you could build the highway and it doesn't matter what car you run over it, but the thing is to build the highway that's sustainable. Are we not leveraging enough inside of health, public health and prevention together? Do we go our own way too much?
Sure. We talk to ourselves, listen to ourselves, and answer our own questions, and then realize at the end of the day why nobody knows what we're doing. And it's because we don't have the right people in the room. So you have to have the Chamber of Commerce sitting there with you. You've got to have it be nonpartisan and have both political parties or even independents in the room. I mean, you've got to do it in ways that are engaging and collaborative. And one of the things that public health people have got to learn to do better is not talk so much about collaboration, but actually collaborate.
But I also think what I'm hearing you say, Reed, and correct me if I'm wrong, and something that struck me as I was listening to the other speakers, like, wow, Janice, like that is like right on the money for something that we're interested in at the March of Dimes. Yes, I read that paper about environmental pollutants and its effect on babies born prematurely and even infant mortality. And listening to you, Chris, I mean, this is what I'm hearing you say, that there are these big issues that resonate across multiple organizations, and we do talk to each other.
Right.
And so for all you out there, we do, particularly our government affairs offices.
Right.
We do, but maybe we need to have more public forums, I think that's what you're saying, around some bigger topics that resonate across. You're smiling, so I think I'm getting your point. Is that right?
So far, I'm just trying to make sure how bad I'm going to get beat up here.
No, I agree. I mean, we intentionally have been working closely with the medical and health community on areas that are traditionally labeled environmental to help raise awareness that these are really public health issues. And that awareness is not only awareness within our own organizations for the ramifications we're talking about, but within the political process, but also within the community. So that people, we find, sometimes people do not take environmentalists all that seriously. They see them as somebody that's kind of on the left and not necessarily representing their concerns. And so we want to make sure they see that it has fundamental concerns, fundamental impact on everybody. Someone in everyone's family is our way we talk about it. And it's absolutely true. And we work very closely with these organizations and others.
No, I think you really hit it. But I think what I'm going to do is ask us at the foundation to think a little bit more about some of how to pull some of these things together, how we can highlight the opportunities for more collaboration. Because if you're a CEO, what you get is somebody's come to you with a compelling thing. You should be involved in this. Okay, I'll do that thing. And then you don't do the other stuff. So, because you got your thing. Everybody's got their thing. And what we got to figure out is how do we sustain a team sport, comprehensive, integrated thing where we can do multiple things off of common platforms. And that's going to require, I think, some different kinds of thought. We got 2 questions from the audience. And identify yourself.
Yes, my name is Jan Heinrich, and I'm currently with the Centers for Medicaid Care Services and the Innovation Center, and have been working closely with the State Innovation Model, SIM, where the focus really is on changes at the local level. And it's engagement of all the players, all the parts of our society in making determinations about priorities and then the actions. But again, it's so important to have the measurement component of this so that you can actually document the change. My question to all of you would be, as you've gone about making changes, are you currently working with the state governments, the local governments, and leveraging the policy levers that they have available to make these really important changes?
I can tell you that we are. I mean, through our affiliates at the state level, particularly working around issues around the community benefit effort that hospitals have in terms of bringing together collaborations that cross sectors. So in addition to bringing the health sector in and the core business sector, you're getting architects and engineers and law enforcement to sit in the room and how to figure out how you can make healthy communities and how you can move far upstream to begin to reduce healthcare costs.
Reed talked about leadership. You used that word earlier. It's a very important word, and I think, and as an example of what you're asking, a couple of years ago, we worked with ASTO, the Association of State and Territorial Health Officials, and an incredible leader in the state of Texas, the Commissioner of Health, David Lakey, was the president of that organization for that year, and he created a challenge. He worked with us, he worked with other organizations. So ASTO and the March of Dimes partnered, and we challenged state health officials, lead state health officials all over the country to take on a pledge to reduce preterm birth by 8% by 2014. So not to 8%, but by 8% from a 2009 baseline. So we did leverage that, and it's the leadership. Leadership is so key, and particularly local leadership. And so we also work with AMCHIP, the Association of Maternal Child Health, AMCHIP, Association of Maternal Child Health Programs, and then you mentioned NACCHO, the National Association of County and City Health Officials. It's all about, to me, and I hope Georges would agree with this, it's that local public health leadership and the partnerships that sort of go around that.
I would add, in the case of the American Cancer Society and the American Cancer Society Cancer Action Network, we have 3 million volunteers with the American Cancer Society that are all over the country, 1 million with the American Cancer Society Cancer Action Network. You're thinking that equals 4 million. No, part of the 1 million are also part of the 3 million, so it doesn't actually add up that way. But the point is we're engaged everywhere. I mean, we're in every state, every congressional district. We have health systems work going on. I think the challenge goes back to the question that you asked previously, Reed, about how do you get people, how do you integrate all of this? And I think the biggest thing that we have to overcome when we're working in all of these levels is to be integrators and to also work with the people who don't inherently agree with us on everything, and to make sure that we are really putting the information in front of the people that aren't active as they ought to be working on these issues. Because a lot of those people, like CEOs, when they see the right information, they do respond. And I think that we, as a community, have to get better at that.
I think one of the things I don't want to lose from Janet's point is just the very nature of where she works. So this is the Center for Medicare Services Innovation Centers. And as we know, our federal budget for Medicare is in deep doo-doo, right? That's a technical economic term. There is no way that your government can afford to pay more for medical care in America. It has to change. And what is happening through the leadership of CMS and the Innovation Center is to move us to this population model. This population word, Georges, used to be the sole province of public health. Now you're hearing population be owned by the delivery system. So there is this new chance to have this synergy between traditional medical care and traditional public health. And so we're in a new era here. And I think that this is one that we will be very smart and wise, we must be, at riding the wave of how do you stitch together the Medicare program for medical care with true public health and population prevention. And so I'm glad that you sort of are here and raised your point.
I'm Bob Griss with the Institute of Social Medicine and Community Health. I think we have a tendency to use the same terms to mean different things. And population health is probably a good example of that. When the private sector uses population health, they're thinking about their members. They're thinking about the people that they're at risk for. They're not thinking about the total population within a geographical area. I think the distinction between public health and health care needs to be thought about differently. We don't think about competition among public health agencies within a geographical area, but that's what we rely upon our healthcare sector to do, to compete, to use resources in ways that maximize profit, as opposed to promote the public health, the population health in the most efficient, effective, and equitable way. That transition I don't think we've made in this country. over the 25 years that this survey has been taking place, and I think we need to be more aware of the need to plan collectively and use our resources in ways that really do help the total community. I don't see that happening in healthcare. I think there are a lot of tendencies to, even in cancer care, to privatize the types of treatments that are gone after rather than the prevention strategies.
Good, thank you. Any comments?
So I would just like to say I appreciate that comment. I've been in public health a long time, and we have labored in obscurity, as it were. But now all of a sudden, I do think our day has come. So we are popular because of this. We are the one group that can bring that perspective of the whole population. As you said, it's sort of, that's our territory. That is what we do. And I think it's up to, in some ways, governmental public health to get people at the table so that communities can focus on the entire population and make this more seamless than what you're seeing.
Any other comment?
Yeah, I think there's some opportunities to do that. So the moving from pay for performance to paying for outcomes and quality is certainly a fiscal mechanism to begin moving that direction. The community benefit, again, as I said earlier, is an opportunity for us to begin to moving that in that direction. We're seeing several states which, as they've begun to redo their health systems and their plans, are beginning to look more and more like community activity. Maryland's going to have an amazing experiment through its all-payer system around community benefit. I think that you should watch Maryland, because I think you're going to see a lot of merging of public health, where you'll see hospitals no longer chasing growth in revenue as much as they're chasing growth in outcome. They'll still make money, but they're going to be looking more and more and more about outcomes. So I think there's an enormous opportunity for us to do that in this country. But I got to point out that the way you get progress is to measure what you do, understand how those measurements occurred, and then do something about the results. Because we have lots of reports sitting on the desk for many years that show good things and bad things, and we've never disseminated that, and we've never been very good at acting on what we see.
I just want to pick up on that and add one or two things. Just back up for a second and just say, let's not forget about the patient, okay, being at the core of this, patient and family-centered care. And I think also, part of what I think you're saying is, and this is a much harder topic that we grapple with, I'm sure all the other organizations here grapple with, but what I hear is, with regards to infant mortality, I mean, that is my niche, and this is my expertise, so I'm going to use that lens, but you could use any lens. Say, if you're really going to impact infant mortality, you have to start one community at a time, one block at a time. You have to deal with issues like America's Health Rankings report talks about poverty. You have to start thinking about poverty, about electricity, about food, about nutrition. I think that's part of what you're saying. Those are the big topics that we just can't all wave a wand and change. I mean, our society is going to have to want to tackle those issues. And when I'm told I'll do this one block at a time or one neighborhood at a time, that's a lot of work.
I would also argue for the importance of taking a look at some of these measures that are very large in scale, but are also very impactful when they get put in place. And air pollution, go back to it, is my favorite example of that. One other story I can tell you is Atlanta during the '96 Olympics. Study looked at air quality. Ozone levels dropped by 25%. They looked at the same time at the number of children with asthma who needed treatment for medical conditions, and that dropped by about 40% during that same time that pollution was gone. Now, those are not necessarily things that people think about if you're not taking a child to the hospital, the emergency room for asthma, but you can measure those. And those are systems that we have been measuring to be able to assess that these are steps that can have profound health impacts and reduce the use of medical care, because we're taking away things that are causing the problem to begin with. And that's an important part of the public health approach to all of this.
I think that's really key.
Let me
Yeah,
do
go ahead,
one myth
please.
real quick. The myth that prevention in public health takes 20 years to get an outcome. What you heard in Atlanta was that occurred within days. And so it doesn't. A lot of our public health interventions occur within hours, minutes, days.
I think also the thesis of your question, your point, I think you guys have debated it very well, is if you take this asthma situation and you start with this level of decreasing the air pollution, then you're still left with a residual level. And so once the delivery system, as George indicates, is financially accountable and transparently accountable for the quality of care to asthmatics and the economics of care, meaning keeping kids out of the emergency room, keeping kids out of the hospital, decreasing their lengths of stay, all of which are good for kids and good for the people that have to pay the bill, like the state Medicaid department and your taxes. If you can do those things well, that's important for the delivery system to have a new incentive through things like what CMS is doing. But then if they're going to be successful in the delivery system doing that, somebody's got to be taking care of the heating ducts and the air conditioning systems in public housing. That is public health. So it's this marriage that we have in terms of the population model for the delivery system, the population model for public health, and as George is indicating, I think, a new incentive to stitch those together at that level. We have 2 quick comments.
Yeah, let me say that's one thing that we've been looking at with asthma, particularly because the housing issue becomes so critical and it's so hard to deal with. And we identified a few years ago some tools in that we haven't used in a long time, and that's housing standards and building standards. Those are in every community. Those are ancient public health tools, but only a few communities are using them effectively to help reduce those exposures and those problems. And there are tools that are in place that we can be using.
Well, let me just give just because you said that, I'm going to give this question. I got a commercial I got to give you. There's a report that I'm actually, IOM report that will be coming out before too long. I chaired the committee, and it's just in the process of review now. But it's a novel idea on that, and it's called post-disaster recovery to build healthy communities. And if you think about it, when we have a disaster, we spend a gazillion dollars rebuilding houses and roads and grocery stores and all of this stuff. But health and healthy communities is never at the top of the list. So the idea of this sort of thing, what if you had to create a blank slate and do it de novo? So stay tuned.
Afternoon. David Whitehead from AARP Foundation. And Chris, I with interest, recognized that you made a very important point on the role that good nutrition has in public health. Now, for many people in this room, I assume that's a choice. But there's a large population in this country that would be less of a choice, meaning affordability, accessibility. So what's the Clean Air Act solution to the nutrition issue in this country?
Wow.
Good thought.
That's a great question. How do you make food more affordable for people? Gee, I don't know. I'll say this. First of all, a lot of the things that we're trying to prevent, there's a huge economic factor. I mean, trying to protect people from diseases. You know, I think about lower income people, the ones that really maybe are challenged on whether or not they can afford to have a healthy diet. And unfortunately, what they do is then they consume cheaper, less healthy things like sugar-sweetened beverages, et cetera, which is tragic, and they are more apt to have diseases. I think we have a huge education problem, and the people that we need to educate the most, I mean, obviously, the people that we need to educate the most oftentimes are those that are the hardest to educate. We really have to work on that, and I think that's when we work together when we integrate all of these interests, we've got to do that. The sad truth, and I know at AARP you pay a lot of attention to this, you see a lot of people that can't afford very basic things that they need to be healthy and to maintain a reasonable lifestyle. And that is a huge problem. So economics play into all of this. And how do we make sure that everybody has that ability? How do we make sure that they have that ability when they're young? How do we make sure that they have that ability when they're in their work life? How do we make sure that they have that ability when they're retired? Which becomes, and I think may become even more of a challenge going forward. That's a bigger conversation, obviously, but it's got to be part of the same conversation.
I'm just so glad he asked it, and so we'll let that stay there.
Well, but let me.
Oh, you want to go? Oh,
yeah,
brave
I
man.
got to weigh on this. I mean, let's be clear. First, let's get rid of the myth that lower income people will not eat and buy healthy foods. In New York City, they have an Apple Cart experiment where they are are taking fresh fruits and vegetables, and they have these corner vendors that go in the low-income communities, and they only sell fresh fruits and vegetables. And that experiment has shown that if you give people quality, affordable fresh fruits and vegetables, that they will certainly buy them. Second thing is we gotta deal with poverty head on. It means we got to pay people a living wage in this country. Thank you very much. And if we don't start doing that and start dealing with that, we're going to pay for it in unaccounted costs in other ways, such as poor health and some of the other challenges around violence and things like that in our communities. We have the money, we have the wherewithal to do it, but it's going to again require sound policies, economic policies, to lift seniors out of poverty and lift low-income people out of poverty.
And I got to say that we got to thank AARP for shining a light on the fact that there are such a significant number of seniors who go to bed hungry, and those who are not even going to bed hungry but who are living with food insecurity. It's really a concern.
Jay Glasser, Medicine Public Health Initiative. I was thinking, listening, and thank heavens for all the organizations that have hung in there and are so important, the intergenerational problems. It's not only the immediate, like Ebola, but the intergenerational ones and the sustained effort. And I was at the Rubenstein Center for Rights not too long ago in the National Archives and watching some of the kids play with the interactive displays. And one of the kids turned to the other and said, "Did you know there's a time when we had to work, that you were forced to go to work when you were 8 years old?" And one girl turned to another one and said, "And you know what? We didn't even have the right to vote." So I was thinking about this notion, and forgive the phrase for those who don't like it, common core, of trying to have some kind of integrated message, a base, so that when the Lung Association properly pushes for those things of interest, the March of Dimes, et cetera, that these things could be linked together, and the notion of creating a generation of spokespeople and practitioners of health.
Good for you. Well, quick comments. We're going to go faster on these rounds because we got about 4 people in queue. Who wants to take that?
I'll say we have not been involved in developing curriculum for that kind of activity. Though as an old history major, I can certainly appreciate the importance of it.
Yeah. I think really this is actually very key because our kids are not getting this in school. And they're not being, not only are we not getting physical education anymore, but our children really don't understand. If you think about it, what's the biggest area of decision making that a new adult, a person graduating from high school, has to make? And if you think about it, it's enormously around your health. That's where increasingly your economic expenses are. It's where your risks are. But just think about all the decisions you have to make. An era of genetics where you're making statistical probabilistic determinations about whether you're going to be like Angelina Jolie and based on a statistical probability of breast cancer elements, make a question around prophylactic breast mastectomy. How many kids are learning statistics in school? So I think that you make a great point around how we got to bring health higher on the agenda.
I'm Clara Adams Zender. I'm a retired general from the United States Army, but I'm here today representing the University of Minnesota School of Nursing Board of Visitors. And the question that I have is, the United Health Foundation has been doing this particular rankings for the last 25 years, and they didn't have the tool that we have now in America called the Affordable Care Act. Do you think that since next year will be the first time we may see some results based upon that might make a difference in terms of looking at the health ranking?
George?
Let me start by just acknowledging the former chief of the Army Nurse Corps, General Clara Adams Zender. A very historic person and, of course, an old friend. Thank you, General. The answer is we hope so. My goal, of course, is that we begin to live in a nation where we have a system with everyone in and no one out. And of course, my appeal today is for all of those states to finally decide to take up the Medicaid expansion in any way that they feel they can pull it off, so that we do not leave any of our citizens out of this grand insurance experiment. I'm all for prevention, but at the end of the day, stuff happens. We do get sick, and having a get into the system card is just so very important.
Great. Yeah, please.
I would just add that it's a great opportunity, but it's not being evenly implemented in all states. And so I don't think, as the measures person, I would not look to see a dramatic change. I think we'd be talking about a gradual change as we bring all of the states and all the communities on board.
Good. And I think you all would be happy that there are prevention things built into the bill, which are important. Right. And I think it also, though, comes back to the point that we made from on CMS, that a lot of this is going to be to drive the incentives of the delivery system with the prevention. But let me just say this out of complete respect for your question, and I think it is the great question to ask. At least my point of view, and what I'm just on my own personal soapbox around is, America loves to talk about access to medical care, and we will talk about it forever. I'm here to tell you from my reading of the data, and you guys can disagree, you will never be able to afford all of the medical care necessary to treat this bolus of preventable chronic illness. America has got to stop talking so much about medical care and spend a lot more energy talking about prevention. If we don't turn off this spigot, we are doomed. And unfortunately, and it is so necessary to spend so much time in America to get the Affordable Care Act that everybody went running over to that, and we forgot about all the other stuff. And now we see the obesity rate going up. We see, and so we just, I love your question, it's the right question. But please, for those of you in the family of public health, do not let America lose its focus on turning the spigot off, because if you don't, we're in a crisis. That's just, now I'm back to being moderator.
Well, moderator, could I just chime in for 1 second?
No.
I mean, I'm not going to completely disagree with you, because you said you should push back, right?
No,
but I mean, you know, uh-oh, here he comes. I mean, there are some very good things about the Affordable Care Act, okay? It may not be perfect,
wonderful.
but, you know, women's preventive services, you know, talk about
I said
preconception.
that.
Hold on a second. What? But I mean, it's very important first step. Am I saying what you just said? Yes. Preconception care, dealing with risks up front. Okay, you said it. I guess you said it.
No. I'm just, that's why I said up front. Because you got to be careful in the internet age. Tucson said, lots of great prevention in the bill.
Oh, he did say that.
And that's what I said. And Tucson said, as important as medical care is, and you got to have it, we can't not spend time talking about prevention. Because I don't want the internet people to get me crazy. Okay.
Hard to follow the Tucson said rules, but my name is Woody Kessel, and I'm at the Coop Institute in Dartmouth in New Hampshire. And I want to get back to the granularity of this report a little bit, because we've postulated a number of thoughts about how to improve health in the country. But this report offers us an incredible opportunity to try to drill down and say that there are states that know what to do and know how to do it, and other states that need help doing it. The real question, short of moving the Coop Institute from the former #1 state, New Hampshire, to Hawaii, place matters, I think that underscores. The real question is, from your analysis here, what are the 3 things that Mississippi could do tomorrow? George, you talked about some of the things not taking 20 years. I mean, I think, what are the learnings? What are the teachings from these top states to transport to the states struggling to do better? Everybody wants to do better. The question is, how do we help?
That's a good point. So let me just answer it real quickly and then get to another question. But I think that first of all, you've been fighting this fight for a long time, brother. And I'm telling you, I'm glad to see you here with us today. So without trying to answer it, what I would urge you to do is go on the website and play the modeling games that we've designed there, which will sort of let you move those variables. The second thing is, I really urge you to also to go to the ASTO site and go to the learning laboratory section where the states are actually doing that work with us, because the variables are so complicated and so specific, and you got to move them around. So the answer to your question is so complex, so locally specific. But I think what I love about your question is it continues to emphasize this notion. We have to learn those lessons. Why did New York make the most progress over the last 25 years? How did they do it, and what was it about that? So, but it's going to be very specific. So I think I love it, and go to the site, play the modeling game, and check the ASTO thing out, and we thank you. I had one guy back here.
Yes, Ray Michael Bridgewater, Assembly of Petworth. We are a grassroots organization that concentrates around public-private partnerships. So we help build that. Question is two of our last frontiers of health care, and that's oral health and mental health. I want to address the oral health, and I asked the March of Dimes and the American Cancer Society to address the issues of oral health. The March of Dimes as it deals with prenatal care, the American Cancer Society as it deals with oral cancer.
Thank you. Quick comments?
Sure. Just quickly, in terms of dental care, it's critical. I mean, there have been associations made between good dental care, or I would say the lack of good dental care, and preterm birth. So that's something that is definitely on our radar screen. And I think mental health, I think there's going to be more in maybe next year's report on mental health. Is that my understanding, perhaps? In terms of measures, maybe there will be, but I do think
we're looking for good measures.
Okay, good. But I think that from the March of Dimes perspective, depression, particularly postpartum depression, is a very big issue. It's becoming a bigger issue in terms of mental health. Certainly, post-traumatic stress disorder as well in the context of childbirth. I mean, you don't really necessarily think about that, but these are important issues that we are trying to address.
Let me just say on and I particularly want to address the oral cancer part, because we go through issues like, we have a lot of things that we try to do, creating smoke-free states, workplaces, trying to disincent the tobacco consumption, tobacco taxes, everything. And then people try to have exceptions for things like cigars, thinking, well, cigars aren't dangerous. Well, when you start talking about oral cancers, they are very dangerous. And I think we try to make sure that people are not misled by that, to make sure that they understand that. And then we also have things like, e-cigarettes, where people think, well, this is better than smoking combusted cigarettes. It may be better. Of course, there are no rules around it. There are no regulations. We don't know a lot of things, and we're learning a lot more every day, like the fact that just nicotine by itself, which is the addictive agent in all tobacco products, nicotine is a carcinogen by itself, and there's a growing body of knowledge about that, including oral cancers. I think this is another area where what we need to do is we need to basically educate people. Good. But we need to keep pushing the science so that we know what those causes are. I mean, we know a lot of them. And I think that people are still discovering more, but I think that's a huge issue, actually.
And we're also going to learn an awful lot in the days to come about the role of inflammation on leading to cancer, as well as cardiovascular disease. And so the inflammation that starts in the mouth becomes extremely important. The science on this is exploding rapidly, isn't it? And so that's going to be very important. I'm proud that in the report, we do have measures of good mental health days and those things. I'm happy that in the report, we have good measures on that we look specifically at the availability of dental supply. So we really appreciate your question. Last question.
Hi, my name is Lindsay Haynes Maslow. I'm the Food Systems and Health Analyst for the Union of Concerned Science here in DC. And I just want to follow up on the AARP question about nutrition. So looking at the other side of the spectrum, among our children today, many of them suffer from malnutrition and obesity. And I was wondering if you could comment on what you feel or believe the role of schools should be in helping influencing their diet and education.
Good. Thank you. And it gives us a chance to follow up on Jay's point as well.
I just want to add a thought. I mean, one of the things is that we need to have healthy food in schools, and we shouldn't be able to sell things in schools that we know are not healthy. I mean, there also needs to be education, but there's a lot of work going on right now to make sure that things that are being sold in schools, whether they are sold as part of a lunch program or whether they're sold in a vending machine in a school, that they're not unhealthy things that are actually going to hurt young people.
Obviously the school lunch program needs to continue to evolve to be healthier. And when we have commercial interests that encourage, push back against us doing that, we just need to push a lot harder. Every year, every few years, we have this debate about the school lunch program, and we are making progress, but not nearly as fast enough.
One of the things we learned at United Health Foundation from sponsoring school systems, trying to provide healthy activities in schools around the country, and we did it in 6 major school systems around the nation. And what we learned was it's so important just to teach parents how to cook, how to shop, that doing events in the evening hours with parents and kids around just making appropriate choices. You know, it used to be that you had, Jay used to have home ec classes. You don't have those anymore, or not very many places. So people, you know, we had a big debate once, again, back at the United Health Foundation. We were working with grocery stores and grocery chains, and people, really responsible grocers, were very articulate, saying, look, we can put green vegetables in and but in the day, we got to put instructions how to cook it inside the stalk. I mean, the knowledge base is not there. So we have work to do on a lot of levels. So we're at the end, but we're going to do this. I want each one of you, George, get ready. We're going to give you a 10 seconds to sort of say the one thing that you didn't get to say. I'm giving you time to figure this out. The one thing that you didn't say, or the one thing you said that you want to make sure that everybody understands indelibly as we think about moving from today to where we need to be in America to have the healthiest possible America, the healthiest possible states, and the healthiest possible peoples. George.
Yeah, we're not nagging you. We're health educators, and we're trying to make the healthy choice the easy choice.
I like that.
That's great. So I would just say, being the measurement person, that we want to reduce the variation, and we want to make sure that all populations have the level of health that the one that experiences the highest level has.
I think we need to think about the social determinants of health more. We need to really deal with the health equity issue and get serious about that.
The thing that I didn't get a chance to say, I wanted to address the question from the gentleman from New Hampshire about the state, how states are doing. We're going to be releasing with the American Lung Association, American Heart Association, Robert Wood Johnson Foundation, and Tobacco Free Kids a report about how the states are doing on things. And the fact of the matter is, unfortunately, a lot of times in the name of saving money, they cost themselves a lot of money. They don't invest in prevention programs that will save them a lot of money. I mean, it is the most ultimately, what is it? Well, it's stupid. It's just stupid.
Would you, by the way, just, I don't want to blow it, but we're tantalized by this report. So again, my theme has been working together, working together, working together. So please use our stage to celebrate your report. We want to give you a gift. Sir, what are you talking about?
There's a report, and I have Alyssa. Could you remind us what the name of the report is?
Wait, ho, this is important. We're gonna keep to our values here.
Chris, are you referring to the Broken Promises report
Yes.
that's coming out this week?
Yes.
So this specifically focuses on the Master Settlement Agreement funds and the way that the states are not using those funds to invest in tobacco prevention, but spending it on any other budget items they so desire. And by doing so, as Chris said, we are really squandering an opportunity to help prevent uptake and promote cessation. And that is coming out Thursday.
Yay!
Great.
I will add one threat that we've got to take into serious consideration, recognizing that it is happening now and it has enormous public health implications, and that's the climate change issue. It's not necessarily on public health's thought list, but it is and should be growing because the impacts between extreme weather events, heat problems, disease issues, but also the lack of ability of our systems to be able to respond effectively to those. Things like Sandy, things like Katrina, things like the dust and the wildfires out west are things that we're going to continue to have responses to. And we are working to try to prevent as much of that from happening, but to respond effectively, it will require us to adapt.
That is just such an important point, and you're right. We don't think about that enough, so thank you for being so articulate. Ladies and gentlemen, would you please thank the panel? And now, would you thank yourselves? Thank you all very much. And go online, see the report. Woody, I mean, make sure you get in and look at it, play the modeling game, look at everything we've got there. Stay with us, and above all, we want to see you here next year. Bye-bye.